for all of them. So management of these disorders is equally important, is equally difficult because of the crossing of these diagnostic boundaries. So with changing trends and advances in technology, I think it's time for us to update and equip ourselves as child therapists, psychiatrists, because so much is happening around us. And who better than Dr. Philip John to give us these insights? I would now request my co-chair, Dr. Bhalchandra Kalmik, to introduce Dr. Philip John to all of you.
Yeah, thank you, madam. At the outset, I would like to thank team of the Thursday Musing, Dr. Tufan Pati Series Chairperson, and Amrit Doshi and Alim Siddiqui sir. It's my honor to share the screen with my teacher, Dr. Nina Sawant madam. Today, we have speaker Dr. Philip John. He is a MD from Nimans. At present, he is working at PJ Polyclinic and Child Psychiatry Clinic at Kochi. He has a vast experience of more than 40 years in psychiatry. He is the pioneering psychiatrist from Kerala, both in general hospital psychiatry and psychiatrist. He is the recipient of Vistaka Original
IPS South Zone. At present, he is the co-chairperson of Spirituality and Mental Health Task Force IPS. So, over to you, sir, for your presentation and insights.
Share the slides, please. Chindan, I'll share the screen.
Yes, sir. You can share the screen, sir.
Yeah. Am I visible and audible?
Yeah. Yes, sir. Yes.
Thank you, each of my colleagues who is present here. It's a great time for me to speak to you about some of my personal experiences, coupled with some academic insights that I have earned, we have earned here in this team. And those are what I look at as some of the insights that we have learned, which I'll quickly go through. I must thank you, Tofan and Alim and Amrit and all others who are spearheading this very unique initiative. It's been wonderful. I have attended a few sessions and it's been a wonderful experience. I'm at the same time humbled and honored at the same time to have been invited to this pleasant evening group, which calls itself Thursday Musings. The thought that I had when Alim asked me about what I was going to speak on, I thought I'll talk about a few revelations that I have had on a lifetime of clinical journey, especially with respect to neurodevelopmental disorders. And neurodevelopmental disorders, as Professor Nina rightly pointed out, as a mixed bag today. They are mixed bag because they were distinct and different at one time. And then now we have a haziness of they belong to a mixed bag because of a lot of shared underpinnings that we have, which I will touch upon. This is the center we have. We have psychiatry, neurology, various adult and child psychiatry together here. We have a very large multidisciplinary team in child psychiatry. With this, I'll move on to my perpetual slide. On the new science of mind, I start showing this up in 1990. And that time people used to scoff at me that mind is generated by the brain, that psychiatry is to be perceived and practiced as the application of basic neurosciences to manage day-to-day problems, that psychiatry is obviously a branch of medicine. And if that is so, psychiatric disorders should be perceived as physical disorders, and therefore, unambiguously, psychiatrists are primarily physicians. The objectives of my presentation, there are very many. May begin by saying that I'm an end-of-career psychiatrist. I'm not an academician. I'm a clinician, passionate, as Dr. Nina pointed out, passionate about my work. Most of it is associated with developmental disorders in children. most of it is child psychiatric work, but I certainly see about 30 to 40% of my cases are adults. Long ago, I started as categories of child psychiatric disorders. And as I went on, this is a learning lesson that I want to share with you. As I went on, in my brain, I developed patterns. Initially, I started seeing children with learning problems. And then as we went on, patterns developed. And as patterns developed, as patterns evolved, I had new information, new knowledge. And this is one thing I want to tell the next generation. I have 3 children who are psychiatrists. And I keep telling them, if you do not mix knowledge with your experience across the table, the wider wisdom will not evolve. And as the wider wisdom evolves, that is something that we shared in this place here. And that's a presentation today that I talk of about the wider wisdom of patterns. When we talk about patterns, we talk about patterns of disorders, we talk about patterns of patients, we talk about patterns of parenting, parents, we talk about patterns of various interventions, various remedial strategies. We talk about various pharmacological agents that we use. We talk about patterns that justify the way we find results in the sagacious, judicious practice of child psychiatry that we do. And that is the most important thing, that we have a wider wisdom that evolves, which is ultimately the patterns that we see and the patterns that justify our practice. And that's my presentation. That's an objective of my presentation. So if you look at child and adolescent psychiatric disorders, we have behavior disorders which have moved on to become brain disorders, which is very important. When I was a student of psychiatry, most of it was just hazy behavior disorders, and we have now moved on to specific brain disorders. The thesis that I did under our esteemed great Professor Kapoor, Professor R. Kapoor, he needs no introduction to this country. That was about psychiatric disorders in children. It was a hazy topic. That is one of the earliest epidemiological study that was done. I have been quoted by Professor Malagia Kapoor in her book, where we talk about the Niemann Index. My daughter at Niemann now, 40 years later, from 1980 to 2020, 40 years later, she's working on a very specific thesis, and that's on pediatric OCD, which has been something that has been very close to my heart. Pediatric OCD. So it's so specific. From the fuzziness of behavior disorders in 1980 to the crispness of the idea of individual disorders in 2020. So you have categories like learning disorders, autism spectrum disorders, which actually fit into a wider spectrum construct, as Professor Nina pointed out. We have all these categories today. But at the time, we didn't. We had small little discrete bags of disorders, which really didn't fit into anything. But today, we have moved on to have discrete bags, large bags, but then today, we are looking at having a mixed bag. And we are trying to see what is in this mixed bag. That is another objective of my presentation. In that process, I am positing today that the construct of one spectrum of neurodevelopmental disorders, it's very important to have this construct, because it's important to recognize disorders. It is important to adopt remedial strategies, including psychopharmacological intervention. The construct of categories, we have ADHD on one end, as per our understanding, as per our insights, ADHD on one end, and probably ASD at the other end, which passes through intellectual development delay, which passes through communication disorders of both language and speech, which are totally different, of learning disorders, of reading, writing, arithmetic, etc., passing through developmental coordination disorders and tics, etc., motor skills disorders, OCD, which is very specific and, which is something that I have been talking about from 2004 ANSIPS in Mysore. A lot of people scoffed at me then that OCD could be developmental in origin, but today with Daniel Jeller's papers, we know that OCD in children is developmental in origin, and ASD, of course, at the other end. So we are looking at categories as separate disorders we were, and today we are possibly looking at one single dimension of CAP disorders. If you look at the child and adolescent psychiatric disorders and look across the various categories, we are looking at a very important core issue of relatedness. This term is very significant for me in my practice. We had confusions of evaluation. We had confusions of diagnosis, as Rosanina very rightly pointed out. And therefore, if we have difficulties with evaluation and diagnosis of a category, then we have problems with management of psychiatric disorders in children. But when you look at this confusions arose because there was a lot of relatedness of categories of diagnosis to each other. Categories are separate disorders in child psychiatry. They are related by symptoms themselves to each other, of course. As in neurodevelopmental disorders, as of what we find in ICD, communication disorder of language and speech, of motor or scholastic skill disorders, of motor skill disorders. You have separate disorders which are related by symptoms. Now, more based on the clinical experience like mine over decades, coupled with, of course, research-based evidence, we seem to be moving from the categorical to the dimensional understanding. Like in many other areas, you look at areas where you look at salience dysregulation. We're talking about depression, MDD, you're talking about depression with psychotic disorders, to schizophrenia at the other end. We are looking at the whole thing, the whole gamut at one time. So there is evidence which is robust today, that no psychiatric disorder fits sharply within the boundaries of one single disorder. Why is this so? Unlike other areas of medicine, why is this so that we can't fit one psychiatric disorder into sharp boundaries? It's because I think every mental function is so exponentially connected through neural networks. We have moved on from neurotransmitters to neural circuits to neural networks, and we may move on more as the understanding of how the brain functions evolves finally. Symptoms as diverse as trichotillomania and checking rituals, they fall under the same rubric because of this. There is enormous amount of connectivity across brain areas which observe various functions. And the relatedness, again, is also coming into the area of overlapping of neurodevelopmental disorders. Many symptoms overlap, as in ADHD and LD. Right from the beginning, when I started our work, we knew that ADHD is sort of ubiquitous. It cuts across all diagnostic categories in a way. Overlapping, therefore, broadens the components of comorbidity. Like ADHD, it cuts across all other NDD and occur together. So there is a need to look at relatedness. And this is one journey from categories to dimensions, which we see through relatedness or common sharing. So it's not only the symptoms that we look at in terms of common sharing. We look at relatedness which have common underpinnings, which are similar underpinnings at least, ranging from genetics, studies in epigenetics, neurobiology with neural networks, corresponding symptomatology. That's the fourth one. And the fifth one, the shared response to pharmacological interventions, RTI, which I think is very important in my practice. These shared factors, they are evidence-based. It's not somebody's figment of imagination. It is evidence-based, evidence from genetic studies, epigenetic studies, molecular biological studies, clinical research, and of course, to a great deal from ordinary practitioners like us who have over the years, over decades, acquired experiential wisdom, ECPs like me. So we are moving then from categories to domains. As I said, etiology is shared. When you look at NDDs such as neurodevelopmental disorders such as ADHD, ID, other neurodevelopmental disorders like communication disorder, coordination disorder, learning disorder, ASD, etc., there are shared risk factors again. In addition to the etiology, the risk factors are shared. Symptomatology is shared, of course, as I mentioned. And very importantly, as I again alluded to, there is a response which is common to pharmacological interventions in these disorders, which create domain underpinnings, which are shared. So that's why we move from categories to domains. Our end of career psychiatrist wisdom at Cochin has been that the effective treatment of one category in child psychiatry also ameliorates another, which is again very important. So if there is an amelioration, a response to management which cuts across categories, then we have this argument for dimensional spectrum construct, a dimensional spectrum construct. So that takes me to my small journey from 90s. It's a small CGC journey. As I said, I'm an ordinary practitioner, but passionate, operating from a cubbyhole in Cochin. PJ's CGC at that time began as a center to evaluate and remediate poor school performance in children. We started with poor school performance or PSP because that was the path of least resistance for both parents and teachers. So we started with PSP. If I wanted to announce that I'm seeing children who are agitated or depressed, it would have been very difficult for me to start up with child psychiatry practice. So when we started, we thought of taking up only poor school performance. We deliberately did it at the time. Because one of the major problems that we had when we spoke to teachers and parents alike was the difficulty for them to teach their children, many of them actually. So we realized after a few, looking around in a few schools in and around Cochin, we realized about 20 to 25%, 1/4 of a class have poor school performance, afflicted by silent neurodevelopmental disorders, silent handicaps, skill deficits which go undetected or undiagnosed, learning disorders, ADHD, communication disorder of both language and speech, and intellectual disabilities, which are not found unless deliberately looked for. So we developed with the assistance and collaboration with the country office, WHO,
that's all, no?
Can you please mute your audios, please? A lot of people talking. So we actually formulated a flow chart which we used in our clinic, as well as this was made for the staff room of many schools where we personally went and taught the teachers. We talked about the poor school performance, the causes in the child, the physical causes of vision or hearing, silent epilepsies or other physical disorders. We talked about the need for looking at their intelligence and their development, like walking or talking language or locomotion. We talked about communication. We talked about their ability for expressing ideas. We talked about the fact that these are neurological disorders, their difficulty to handle a pen grip or handwriting, to use an instrument of writing. We talked about LD, dyslexia at that time. We told them that they have normal IQ, or they are much heavily accomplished. They can listen and learn very easily. They can tell you the answers, but they are unable to write it on paper. Therefore, there is a discrepancy between what they know in their head, what they are able to write on paper. And therefore, they need assistance. We talked about ADHD and, of course, anxiety, depression, oppositional defense, etc. And that is another learning process that we had, that the teachers would be the greatest tools for actually helping these children. The other revelation, I would probably put it into some sort of an order, which is the question experience in school mental health. We, as I said, we started because we understood that psychiatry or counseling would be stigmatized. Parents and teachers would be hesitant to send children across to us. But poor school performance, PSP as we called it again and again, and learning disorders, they impact parental pride, especially in Kerala, in a very performance-oriented society like Kerala. It impacts a parental pride. So it forces parents to seek help. And of course, prompted by teachers. So we use PSP, therefore, as a fishing bait. And then they seek help. The parents seek help or the teachers seek help, both seek help. And help seeking results in an evaluation of PSP. This is a comprehensive evaluation done by our MD team, our multidisciplinary team of PSP, which would include not only academic aspects, but each of the other neurodevelopmental problems as we came to know as we grew in the profession. We looked at emotional problems, we looked at behavior problems in the child. And then we looked at this huge problem that we have today. Why are we having the national education policy, which is going to be skill-based? I have never let my schooling interfere with my education, said Mark Twain. There is a discrepancy, there is a gap between schooling and education. Schooling is about the 3 R's that we usually speak about, the reading, writing, arithmetic stuff. And education is probably identifying your skill, your talent that God has given in you, with which you are going to do well, with which you are going to actually stand on your own 2 feet and earn a living at the same time, live a passionate life. And that is the second part that we came to. As we went on with the difference between schooling and education, we realized that there is an astounding fact on our long-term follow-up, that children with skill deficits in 3 R's, reading, writing, or arithmetic, many of them go on to become success stories using their alternate skills. These are the skills I mentioned before. These alternate skills are the real world skills, the head and hand skills. You see this generation going forth like an arrow. They use their right brain skills mostly. The CGC mission today, therefore, is to propagate in schools and for children and to children. You look for skills. You deliberately look for skills instead of skill deficits. He doesn't write. He's obstinate. He's stupid. He's lazy. Instead of that, you bridge the gap between schooling and education. This transformation, this parivartan into future success is education. And I think that's a second lesson that we learned. And that brings me to a small gap where I just mentioned the neurodevelopmental disorders that cause poor school performance. And this is the mixed bag that we talk about. We had this inkling right from the beginning that we are not just talking about learning disorders. That is what we were talking about initially. But then we realized a lot of these children had communication disorders. Even if they knew what they wanted to say, there was a difficulty. They would use a lot of unnecessary words. They would go on and on. They would use fillers, like, etc. And they had difficulty to communicate what they already knew and what they had studied. A lot of them had difficulty in holding a pen or buttoning, or a lot of them had developmental coordination disorders. So it is not just LD. But then when we looked at the specific developmental disorders in F80 in ICD, you realize F80 is here, and F81 is communication disorders of language and speech. F81 is there, learning disorders, and F82 and developmental coordination disorders associated with tics, a lot of them. That is when we realize ADHD runs across in all these disorders. But if you look at ICD-10, you would realize ADHD and the tics are included under behavior and emotional disorders in children. Something that is as neural as ADHD. something which is as neural as ticks in the nigrostriatal pathway, how can you include them as behavior and emotional disorders? So that is one of the mixed bag that we actually reconstituted to identify in each child who comes to us with poor school performance. We also looked at ASD. We had identified a lot of Asperger's. One of the child whom we had seen at that time today is a very well-renowned sub-editor for a well-renowned magazine in India. OCRD came much later. When we went on, we realized there were a lot of children with obsessive features, obsessive traits, obsessions without, compulsions without obsessions, etc. And we realized that also is developmental in origin. In 2004, I presented this in Mysore Answers. And now Daniel Jella says it is OCRD is developmental in origin when it occurs in small children. And we have these emotional disorders, which also we have to identify needs, especially children who have OCRD, OCD. They go on to develop ODD, oppositional defiant disorder. A lot of them have intermittent explosive behavior. If you don't connect with them, if you don't actually remediate them, they are going to get into severe behavior disorders, which may even go on to ASPD. Emotional disorders like depression or anxiety, a lot of drug use that you see, a lot of criminality that you see, a lot of delinquency that you see is possibly the result of not intervening when we find these difficulties at this stage. So you identify individual disorder in each child. And treatment of one disorder, as I mentioned before, certainly ameliorates another. This is again the same thing. Only thing is I wanted to show you that as we went on, even without DSM-5 or ICD-11, we included ADHD into this and obsessive disorders, especially children with this difficulty with change, with the anxiety with change. We included them also into this developmental disorders, into that spectrum of disorders at the time. And this is, of course, we are talking about the structured information to diagnose a disorder, which is the difference between DSM-4 and DSM-5. We have a diagnostic manual today, which is sometimes helpful in a consultation room approach, which is helpful because it is a developmental issue being represented based on evidence, and it has a lifespan approach. The genetic and neuroimaging linkages across diagnostic groups. Dr. Nina mentioned this in her introduction, across diagnostic groups, and therefore ID to ADHD as neurodevelopmental disorders. In ICD F70, we have 90. Unfortunately, this F group, which is psychiatry, has been taken away by your pediatrician colleagues. It has been taken away by your neurology colleagues, and our leadership is not doing much to get this back, or at least keep some of it with us. Although today we find that this is clearly these disorders, the neurodevelopmental disorders, they clearly belong to psychiatry, the F block. We have them here: the intellectual disability, communication disorder, language and speech. This is something that I think we have to. I spent half a minute on this. Why is this called disability? Because there is no response to intervention. Many of our colleagues still keep on using learning disability, communication disability. I do not understand why we talk of disability when there is a response to intervention, when there is an RTI, response to intervention. In language and speech, language is the CPU. Speech therapy is not what you give for a child with autism. You have to get across to the CPU and change or repair the monitor. And that is language and speech. Autism spectrum disorder, attention deficit hyperactive disorder, specific learning disorder, and developmental coordination disorder. Now, again, this is part of the journey. The third point I already made a mention about, that hyperkinetic disorder or ADHD and tic disorders were included, unfortunately, under behavior and emotional disorders. We had difficulty accepting it as a behavior and emotional disorders. We had the great opportunity to meet up with Dr. Dilip Juste when he was APA president during the DSM-5 days. We had a long conversation, and now we are excited to witness the change of even ICD, F70, 80, 81, 82, 84, and the 1995, 98, I've come across into the 88-1 subgroup. So all of them are developmental disorders under the same rubric. The fourth lesson that we learned, the revelation that we had, I mentioned this before. These children get on to absolute successful lives as they grow older. These children who are written off in schools, these children who are written off by parents and teachers. Because as I realize, this is a very, very, amusing slide that many people look at. When everyone grows up, all of us know, the A grade students, they go on to work for the B grade students. I was an A grade student, perhaps. I topped the school final examination in Kerala. I topped 300,000 children. But then where have I got? I got into a cubby hole in Kochi. But where are my classmates who are B grade students? I have a friend who took about 6 years to pass his MBBS. But by the time he finished his house job, he had already built a hospital. And many of our classmates who got gold medals were actually picked up by him early in their careers, and they went on to make a great amount of money for him in his hospital. So the A graders, they all went on to work for the B grade students. If you actually remember many of your classmates at school, the C graders, they run all the businesses in town. I can actually count at least 3 of them in this town of Kochi. And the D students or politicians, they go on to dedicate buildings and bridges to the nation. So poor school performance, it is never a parameter of future success. It's a lesson that we learned, a revelation that we had in our journey. But why is this discrepancy in later life? And that is the neurobiology of the whole thing. I don't know whether some of you would have read this book, Soul in the Brain by Mike Trimble, the behavioral neurology chief in Institute of Neurology, London. He talks about why we go to the opera to cry, because it's associated with a strong bias in the right brain. Similarly, we realized as we went on that children who have this great attraction to motors and machines, computer, mobile, remote, doing things with their head and hands, the head and hand skills, music, dance, acting, mimicking, all these things, painting, fantasy, imagination, writing stories, sports, games, designing, crafting, cooking, homemaking, or leadership skills, a lot very strongly right brain dominant. And the others, they are the tabletop hemisphere children. I derisively call them the tabletop skills or the paper pencil skills, because I myself know that I'm so bad with my right brain skills. But this exclusivity did not reach me anywhere except this cubby hole from where I'm talking to you now. Reading comprehension, writing, spelling, arithmetic, listening and speaking for communication, use of languages. These are all things that you see in the left brain, which are the skills used in school. So what are we looking at in our in evolving a meaning for this? That is the 5th revelation that we saw. If you look at the right brain skills, all these things that I mentioned, they go on to create vocations, especially in this 21st century. Schools pass a child based on the sit-down test, the left brain sit-down test. But the real-world intelligences today, which cannot be tested on tabletops, music or dance, acting or mimicking, fantasy or imagination, crafting or designing, drawing or painting, sculpture or horticulture, navigation, exploration, cooking, homemaking, every one of them, stitching or sewing, sports or games, motors or machines, repairs or mechanisms, life skills or leadership skills, management or team skills. Imagine how many vocations can be generated out of these skills, these few skills which are in their right brain, to convert seemingly hopeless children in schools to wildly successful ones in life. We see them all over and again here these days. And this is the other lesson we learned, the 6th one, that looks at a 5-finger approach for prompts or counseling. Any of these, intellectual disability, communication disorder of language and speech, learning disorders, developmental coordination disorders, obsessive compulsive disorders, and ODD, oppositional defiant disorder, we use this 5-finger approach for parents to understand and remember, for teachers to understand and remember. We also talk to the children after we have spoken to the parents. Limit setting and parenting, extremely important. We remember our own teachers. In the classes of teachers who are firm and strict, we all learned much better. So there is a need for limit setting or structured environment. Parenting, like, father is a friend, I think it's all nonsense. Parenting should be without shouting, without yelling, without screaming, without pinching, without beating, without bribing or bullying. There should be a certain amount of personal space that you keep with children. The teacher should have a personal space with the pupils. Pharmacotherapy is my second. And behavior modification, academic intervention, language and communication, all 5 apply equally to NDD management. All 5 should be there, especially the thumb, without which this hand is useless. Emphasis on pharmacotherapy is the 7th lesson I learned. We shared phenomenology across NDD. And that means there is a shared response to intervention. As an example, hyperactivity may run across all NDD, as I mentioned before. So if you treat one disorder, you ameliorate another neurodevelopmental disorder. This is a slide on which I'll spend 1 minute. Serendipity and disclosure. This is the first time that I'm doing this probably generally. This is a pioneer revelation that we had. About 20 years ago, Professor Ehsan Musa, he's a chair of neurology in Harvard. He referred a 3.5 years boy with ASD to us. He had paroxysmal spells of fear. So because he couldn't talk, he couldn't even walk well, he was referred to us as a psychiatrist. But I was fortunate, the boy was fortunate, and thousands of children after Adil were fortunate to have produced one of these CPS in front of us. He suddenly got into a fright and he held his mother's upper arm and looked at her, and I saw him drooling. I quickly took a torch and looked at his pupils, which are dilated and non-reactive. I started him on carbamazepine, as that's a preferred drug for me for CPS. So in about 3 weeks, 4 weeks, his mother Selma came running and told me, "Doctor, he looked at my face and called me Uma for the first time, called me mother for the first time." We went on, we continued management. I told her this is a massive synchronous discharge of the electrical storm which has been quietened by carbamazepine. She wouldn't agree. She continued to give the medication and pray. And in a few months' time, his locomotion improved, his language improved, his communication incredibly improved. The other was fluoxamine, about which I have spoken across the country several times, on neuroplasticity, on fluoxamine, on sigma-1 receptor systems. When I started using it for insistence on sameness, explosive behavior, etc., when we gave a trial after 6 years of their age, currently in regular use. This is another amazing thing that happened. The other is, of course, methylphenidate. When I'm talking to you, if I don't concentrate, if I don't sustain attention to an ongoing learning task, I will not learn the task, so I started using methylphenidate. So there is a rational polypharmacy. This will take another webinar to contemplate across all NDDs, including ASD. I hope to be published soon if things go well. So once that happens, of course, this will be peer reviewed. So that's another peer reviewed evidence that we have of an autistic brain. Many of you would have seen this book or read this book, Ms. Temple Grandin. Adult Thosis, she's a professor of veterinary science in University of Colorado, USA. She reports in this book from the forefront of autism science, from her own experience, how she was thrown from pillar to post by all these therapies: speech therapy, language therapy, autism therapy, ABA therapy, this therapy, that therapy. But once she realized it's a brain disorder, she was given the support of medications. As one of the remedial strategies, she made it to be the professor of veterinary science in Colorado. This is another major perspective that we have. And that is where it comes to management with medications. We look at stratification of autistic disorders. Stratification would be low functioning children with comorbid disorders like intellectual disability or epilepsy, or high functioning ASD children, which would be pure ASD. They would have actually developed skills to talk, skills to walk, but then they actually stop dropping these milestones at some time. The ASD comorbid with intellectual disability, they are the low functioning. They are the no treatment ASD for many psychologists and many autism centers. No treatment. ASD has no treatment. Psychiatrists are fooling you. The other is where psychiatrists are not fooling them. Pure ASD. They are high functioning. RTA is possible. Polypharmacy is providing relief. So if you look at pure ASD, you have deficits in connectivity. I mentioned before, DTA studies today show this among brain areas, the neural circuits. So it's more about neural transmission in pure ASD than signal transduction. Signal transduction, the cells don't function adequately, and that is low functioning. So the high functioning ASD, therefore, they are more amenable to strategies of intervention, where we can increase signal transmission, including with pharmacotherapy. I would quickly go through 2 slides, and that will be my last slides. Autism, the NGO industry. Exploiting hope against science. There are so many of them, even in this small town. The late talkers, they are undiagnosed. The late talkers are undiagnosed. They are given the speech therapy. Many of the pediatricians say that he's going to be all right when he's 8 years. By the time the pruning stage is over. So what are you going to do to them? The pure CDs, the other group, they are unfortunately misdiagnosed. They are lifelong, they have a label of autistic disorder, which is so sad. They go to the special schools with excellent intelligence. Their only problem is CD, which can be easily overcome. The other is the multidisciplinary team, minus the medical. They will not allow any medical to come in. It's all speech therapy, language therapy, as I said, ABA therapy, this therapy, that therapy, occupational therapy, physiotherapy. No treatment for ASD except therapists. And the agonizing and misinformation, which has actually come down now, MMR and vaccinations that they produce autism. The gluten casein-free diets, oh my God, it's terrible. We have a pediatrician in the city. Ultimately, these children, they come with the protein calorie malnutrition. They have a lot of CH or carbohydrate drive, I agree. But we have to modulate them. It is not to stop them from having casein-free or gluten-free diet, having these free diets. Diets are certainly a nuisance. And now, as has been going on in the groups these days, stem cell therapy for autism is another fraud that's being committed on the community. It's my last slide. That's the hopeful future. The roads ahead will all finally meet at the happy junction of medicine. My firm trust is that the next decade of psychiatry will be defined certainly by spectacular pharmacological interventions in neurodevelopmental and neurocognitive disorders. I may not live to see it, but of course, that will be for the generation next of psychiatrists. Thank you very much for your patient listening. Thank you very much indeed.
Thank you so much, sir, for a wonderful deliberation.
Wonderful.
Thank you. Thank you.
We can invite opening comments from the chairpersons, then we can proceed to the question answers.
Thank you very much, sir. It was an excellent talk as you took us through your clinical experience. It was all evidence-based as you told us and gave us your journey right from starting your CGC with poor school performance. And I just want to ask you one question. There is a lot of literature coming on psychobiotics in especially autism disorders, and because they're talking about the gut microbiota and because of the gut-brain axis. Would it actually help?
I think so. logically it should help, but then I think if you look at the evidence, that is really sparse. The numbers that are involved, the modalities through which these were investigated. But we already know that the little brain, the gut, has so much to do with the serotonergic pathways, which are actually essentially involved in children where there is a restricted repertoire of activities and communication. So therefore, there is a reason to believe that a lot of these stuff that these people are talking about in terms of gut allergies, that has to do with the poor resistance of these children to gluten, if that is there. So similarly, you could actually have stuff that will actually improve the functions. I use to some extent to people who can afford, I use L-carnosine. I have several parents who come and say, it's a turnaround medication. One of the mothers who is working in this field, who was generally against doctors and allopathy, modern medicine doctors and their medications. She has finally come around and she is telling me, doctor, after adding this has made a lot of difference to his metacognition. Metacognition is something that I look at very closely in ADHD, in ASD. Because the ability to understand large meanings from the little things that you see, from the little things that you hear, from the little things that you experience, that I think is the crux of the learning process, which doesn't happen because the individual islands develop in the autistic child, the child with autism. Individual islands develop, they are not connected by these bridges. You would find that the myelination is low, or you would find that there is definite delay in the development of the connectivity. There is a lack of central coherence, and therefore you will realize that they don't have the learning process in place. So there also, I think some of this might help. I really don't know yet.
Thank you so much. Dr. Balchandra?
Yeah. I think child psychiatry and all these things are in the genetics of sir, and he's carrying it to the next generation also through his daughter. So nice lecture. I think evaluation and diagnosis of child and adolescents need special skill and lot of patience plus experience that is grown by day-to-day experiences. There are certain child-specific disorders, like sir told that LD and ADHD, plus other emotional disorders also, which need special attentions and vision. And that is the mixed batch we have to look after. So other things like sir told that it needs a multidisciplinary team like psychiatrists, psychologists, counselors, social worker, and occupational therapist. And most important, the cooperation of the family member of the child. Plus, there is need for the special association with the school also, because most of the schools are not accepting that these are the problems, and for any reasons, for the bad name, schools are not also coming forward for such reasons. Sir also emphasizes on the 3 skills about real world and head and hand skills, and right brain, how to use our right brain. Now, sir told that the PSP, that is the poor school performance, is not poor school performance is not the parameter of success. So we should use both the sides of the brain, that is left brain and right brain. As we know that this need the multidisciplinary approach, but we should not forget about the medications, because medications will play the main role in all this treatment. That is rational polypharmacy or rational psychopharmacotherapy. And one should be aware of the pseudoscience. That is, a lot of pseudoscience is coming nowadays. So told about the stem cells, and I think NLP, neuroleptic NLP, that is neuro-linguistic programming, is also coming for such children. So one should be aware about all these things. So I think this is the synopsis of sir's lecture. So over to moderators.
Wonderful summation, Balchandra sir. You have done what Alim would wanted to do. So, so a lot of things which are discussed. It was huge. If you really go into the depth, he has covered almost maybe 30 years of what you would have gained if you would have been practicing in 30 minutes. That's wonderful. And it was in a continuous flow. It was all connected, and maybe it will take us more time to understand the nuances of what sir was speaking. Alim, you want to carry forward what Balchandra sir talked about?
Yes, sir.
There are many questions in the chat box, so sir can go with.
We'll take it, sir.
Sir, there is a question. Let me start from this. Can any drug work to improve intelligence? Many pediatrician neurologists use Ayurveda. So cognition, intelligence, your take on this?
Basically, I think if you are looking at intelligence, it has a lot of components. That's why I have very little trust in checking intelligence, because there are various intelligences. There is something called naturalistic intelligence, for example, or your direction and navigation intelligence. These are all skills that we cannot measure. But training is something that definitely can help. There is no doubt about that. So you can have strategies for improving the way you function. And intelligence, as we know today, is about adaptivity. It is not about one particular skill. It is not about reading or writing or arithmetic. It is about adaptivity. And if you look at that, the way of improving that is not necessarily by using any drug, including Ayurveda. The other aspect is, if we can increase connectivity by increasing like I talked about, one of the drugs I talked about was carbamazepine. VSSC, the voltage sensitive sodium channels, it stabilizes the neuronal membrane. The ligand-gated channels, they improve the neural transmission because they go through the synapses. And there is a greater synaptic connectivity which is produced by an anticonvulsant. So basically, you'll find that in children in whom this is used, there is a greater understanding of what goes on. I was talking about a child the other day. The child was told he was rocking his father's rocking chair, and his his foot would have been caught under the rocking chair. He was told not to rock. He was not told not to rock. He was told your foot. And immediately he stopped his rocking. He looked underneath the chair to see which part of the chair would hit his foot. And he adjusted his foot accordingly. This is metacognition. This is the ability to understand large meanings for the one little thing that you was told, your foot. So that can increase by training, that can increase by medication. For this child, it was very clear that increase by medication, because child was on medication only for 2 months. Before this child had hardly any metacognition. So when you increase connectivity, when you use drugs that will promote interneuronal neural transmission, there is definitely going to be an improvement. Which drug will produce this is the question. Whether ashwagandha produces this, whether many of these drugs that are marketed these days, whether they produce it, is anybody's guess.
Sir, coming to pharmacy and child psychiatry, sir.
Yeah.
It's a major issue now. Now, suppose if the child comes to us first, and then we refer it to any specialist, be it a counselor, be it a speech therapist, be it occupational therapist.
Right.
There's every chance of the patient not coming back to us, sir.
Yes.
Because they tell that already the parents have those things in their mind, that child and medicines, it's almost like poison. It takes a lot of time to convince somebody to take medications, even if it is absolutely essential. And once they reach out to somebody who puts that, who actually, that belief is intensified, that why are you giving medicines, and then we lose the child. And after 2-3 years, when they come back, they're in a bad state. How to go about such things, sir, in a practice?
Amrit, I certainly respect what you told me now, but see, Kerala has changed, for example. How did it change? There is a lot of education going on through various modes, through the media, to the print media especially, and through word of mouth. I have no advertisement yet. But through word of mouth, I'm not claiming to be proud about this, but then for the next 1.5 months, I am sort of totally booked up. Word of mouth. So how this happens is, somebody says, I told you about a mother who was so much against modern medicine and psychiatrists who practice. My child will be like a zombie, is what she told me. I don't want you to give any medication which will make my child a zombie. But she is now very enthusiastic and she's sending so many people to us. So the proof of the pudding is eating. The problem lies with us, Samarth, a great lot. Because in the moment somebody diagnoses ASD, the child is put on Resnia drops. I don't know which company that produces that. See, it's a dopamine receptor blocker. How are you going to actually produce improvement in the child except to make him slow down? The parents are happy because after giving this, the child sleeps in the night. These children are usually night owls. They don't sleep in the night because the brain is irritable in the night. They sleep during day. So the parents want to sleep in the night. So when they give Risnia drops or whatever drops in the night, the child sleeps in the night. But then that child also gets up in the morning and is drowsy. Child has excessive daytime somnolence. So they say, we told, your medicine. And if the child worsens after risperidone, the child, the natural tendency is to increase the dosage. And what happens to the child? So the bad name comes back to the profession, not to the individual who writes the medication. The bad name comes to psychiatry because we use the wrong medication, the wrong dosage.
Sir, there is a question about this in the chat box. We are using risperidone left, right, and center.
Yes.
What are the other drugs that could be useful in ASD spectrums?
Okay. It's a lot individualistic. Because I am not yet published, it's difficult for me to actually openly talk about this. But I'll come back to this again. What is it that you need? You need connectivity, correct? You need connectivity, you need central coherence. These are the two things you need. What are the drugs that will improve connectivity? All anticonversions, they improve connectivity. How do they improve connectivity? They improve connectivity by stabilizing the neuronal membrane, by stabilizing the sodium pump. The sodium pump is weak in all these poorly developed neurons. So you improve their function, you improve the sodium inside the cell and outside the cell, you improve the gradient. So you get faster and quicker and more efficient neural transmission. You improve the signal transmission across the synapses. Because, why is it that some children develop language and then they develop language, the synapses are formed, the synaptic strengthening does not happen, the synaptic loosening happens, and then they lose the words that they had already learned. This occurs very usually in high-functioning autistic children. So what is it that you would use? You would like to use something that will strengthen the synaptic neural transmission. So the best drug is an anticonvulsant. I use that drug because I know that this is a particular drug. I keep on reading and researching what new findings are there on this old drug, which is as old as I am, 70 years old. It has crossed 25 billion prescriptions. So the understanding that we have is enormous. And therefore, you stabilize the neural membrane, you increase the synaptic neural transmission, and you get a better connectivity, and therefore this improves. So that is one drug. The other drug is you have to increase signal transduction. Most of these cells are not functional enough. Example is the inferior frontal gyrus on the left side. The language is exclusively a function of the inferior frontal gyrus on the left side, except the ideation thinking that comes from the right tail gives. Now, if you look at the inferior frontal gyrus, you have lexicon there where the words are stored. My English, Hindi, Kannada, all my languages are stored there as words. There is a semantic area right in front and a pragmatic area which edits my words and sentences to talk to you, to convey the ideas that are erased on your right side. So you are actually targeting the speed first. When I am thinking, the signals have to go to the left side, to the lexicon, keep on picking up the words that will mean exactly what I think. And then those words in a box have to be taken to the front area, to the semantic area where the grammar of English is controlled, where the words have to be put together in grammar and syntax to make sense.